I have the pleasure of introducing our very own senior resident, Dr. Anderson Carter, this morning to give us our Grand Rounds presentation. And she is really a true Madison lifer, as she is a native of Madison, went to UW for undergrad, where she double majored in biology and Spanish, stayed at UW for her medical school training. And then, of course, we were so lucky to have her join us here for residency. And as probably everyone knows, she'll be joining us as a faculty member next year. Yeah. So Dr. Anderson Carter has really focused her efforts over her years in school and training on diversity, equity, and inclusion, and she will be taking on that official role within the department, which I'm sure she'll do fantastic things with. And she has won multiple awards during her residency here for her surgical prowess as well. So our patients will be really lucky to have her take care of them. And today she's going to be talking to us about the important and sobering topic of maternal mortality. So with that, I will turn it over to you.
This is Kira Johnson. Her story has been told by her husband to bring light to her fight. She went in for a scheduled cesarean birth. Shortly after birth, her husband noted that her catheter was turning pink with what they presumed was blood. They brought it to the attention of the staff. And at around 4 p.m., they ordered several tests, including a CT scan that was supposed to be performed stat. An hour later, she still had not been taken to her CT scan. Kira shortly after became sensitive to touch and started to lose color. Still no CT scan. By 9 p.m., her husband pulled the nurse aside to ask why they never took her to the scan. And he was told, "Sir, your wife just isn't a priority right now." After midnight, Kira was removed from her recovery room and transported to the OR. The last thing she said to her husband was, "Baby, I'm scared." As she was wheeled into the OR, one of the doctors stopped and told her husband, "It's not a big deal. These things happen. She'll be back in 15 minutes. Kira Johnson was left for more than 10 hours, bleeding into her abdomen. That's fine. When the surgical team reopened Kira's incision, they found 3.5 liters of blood. She died on the operating table, and they were unable to revive her. She left behind 2 sons and her husband. Kira's story is one of many examples of maternal mortality in our country, one of which highlights potential disparities in care and potentials to intervene. And that's what I'm going to be discussing today. My name is India Anise Anderson Carter. My Grand Rounds is on Wisconsin maternal mortality, an overview of where we are and potential next steps. I do not have any disclosures for today's talk, except that I'm not an expert on this topic. This presentation is based on my personal interests and research that I've done based on those interests. I do, however, want to take a second to realize that while we will be talking about a lot of numbers this morning, each of these numbers was a person. They were someone's loved one, family member, and each of them deserved to have their story told. And thus, prior to starting, I'd like us to take a few seconds and a moment of silence to recognize their lives. Right. The learning objectives for today's talk are as follows. We're going to define maternal mortality and its associated measures. We're going to review the Wisconsin Maternal Mortality Review Team and its review process. We're going to illustrate the trend of maternal mortality in the US. We'll examine maternal mortality in Wisconsin. We'll discuss substance use overdose as it pertains to maternal mortality. And finally, we'll outline some prevention strategies geared at improving maternal mortality in Wisconsin. So the WHO defines maternal mortality as deaths from any cause that's related to or aggravated by pregnancy or its management. And this is both during pregnancy and up to 42 days after the termination of a pregnancy. It excludes accidental or incidental causes. This differs from the CDC in that the CDC has extended its definition out to 1 year from the end of a pregnancy. How we define maternal mortality has implications for how we examine the issue. For instance, those who use a CDC definition by nature would include a higher catchment of birthing persons, given that they extend their definition out to 1 year from pregnancy. Maternal mortality is quantified most commonly using the maternal mortality ratio. This is the number of maternal deaths to live births. Less commonly seen and used, at least in the US, is the maternal mortality rate. And this looks at maternal deaths and divides it by the number of reproductive age birthing persons. What gets a little confusing and difficult in the US is that both of these terms are used interchangeably a lot of times. So while some data may say maternal mortality rate, others say ratio. But in the United States and for my talk, irrespective of those two terms, what we're talking about is the number of maternal deaths to live births. Information used to calculate and discuss maternal mortality comes from sources such as vital registration systems, household surveys, coroner reports, and death certificates. The National Vital Statistics System has aligned its definition with the World Health Organization, and it uses death records to assess maternal mortality. The difficulty with this is that deaths may be underrepresented or misclassified. Many times pregnancy status may be lacking, or there's not enough information to fully determine if the death was pregnancy related. Each death certificate is associated with a specific internal classification of diseases code, and they're meant to define the cause of death, which unfortunately these codes don't always clearly depict the cause of maternal death or pregnancy status. In 2003, the checkbox system was implemented on death certificates to help indicate pregnancy status. This one took a lot of time to be implemented and also has its flaws in that there are some cases where individuals were pregnant where it is not deemed on their death certificate, and there are other times in which the death certificate says that they were pregnant and they in fact were not. So our specific state has its own review committee called the Wisconsin Maternal Mortality Review Team, also called the Wisconsin MMRT. The Wisconsin MMRT was established by the Wisconsin Department of Health Services, Division of Public Health, and the Wisconsin section of the American College of Obstetricians and Gynecologists in 1997. The team brings together public health and healthcare experts from different professional organizations that are involved in the delivery of care to pregnant birthing persons in Wisconsin, as well as community organization leaders. The goal is to have representation from multiple disciplines such as public health services, perinatal nursing, midwifery, dietetics, psychiatry, obstetrics, and more. Their goal or their purpose is to identify and review pregnancy-associated deaths, identify factors that contribute to these deaths, and then propose recommendations with the ultimate goal of preventing future deaths. In the review process, maternal deaths are identified using the pregnancy status checkbox on the death certificate as well as the cause of death. The State Vital Records Office also cross-references death certificates of women of reproductive age with fetal and death certificates in order to identify additional cases. Once the data is obtained, perinatal medical records, coroner and medical examiner reports, as well as police reports, social services records are all requested with the purpose of really trying to get a complete history and picture of the birthing person and the circumstances that surrounded their untimely death. The MMRT meets every other month, and during this meeting, they review information gathered from each case to determine whether or not the death was related to pregnancy and develop future recommendations. The key questions that they aim to answer include, was the death pregnancy related? What was the cause of death? Was the death preventable? What critical factors contributed to the death? And what recommendations or actions would address those contributing factors? A lot of the data that I will present about our state has come from data from the Wisconsin Maternal Mortality Review Team, and we'll briefly talk about some of their proposed recommendations at the end as well. So let's start first by looking at what data looks like for the US as a whole. In the early 1900s, the US, like many other countries, started to see a drop in maternal mortality. This was attributed to things such as improved living conditions, better maternity services, safer surgical procedures, improved quality of living and sanitation, as well as access to necessities such as blood banking and antibiotics. So the question is, how did we get from that decline to seeing a now slow increase in maternal mortality? This is data from the PMSS system, and it's looking at pregnancy-related mortality ratios from 1997 to 2019, it shows us that the ratio in the US has gone from 7.2 per 100,000 live births in 1987 to 17.6 per 100,000 live births. Many ideas have been suggested for why we're seeing an increase in maternal mortality in the US. Some of these include the age of childbearing. Delayed childbearing or having a first child at or after the age of 35 has increased ninefold between 1972 and 2012. Additionally, we know that the proportion of birthing persons with comorbid conditions such as obesity, hypertension, cardiovascular disease has also increased. PMSS data from 2017 to 2019 showed that the leading cause of pregnancy-related deaths in the US included cardiovascular conditions, infection, and sepsis. However, we can note that not too far behind these two are this category of other non-cardiovascular medical conditions. It's hard to know what's included in this category, one, because the website did not tell me and I could not find it when I was looking through the data. However, if mental health and substance use are not included in this category, I suspect that we're not getting a clear picture. Data from MMRT teams nationwide was collected from 2017 to 2019 from 36 states. For confidentiality reasons, they excluded states that had fewer than 10 deaths. And the total number of deaths from this time was 1,018. What we see from this data is that the leading cause, making up 22.7% of deaths, is mental health conditions. This category includes death from suicide, overdose, poisoning related to substance use disorder, as well as other deaths determined by the MMRC to be related to a mental health condition. This category was higher than cardiac and coronary conditions at 12.8% and infection at 9.2%. What was presented with this data when it was analyzed was that 84% of these deaths were determined to be preventable. Over time, the mortality ratio for different populations of birthing people have also been affected differently. This graph is from a study that was published in JAMA in July of 2023. And it set out to quantify trends in maternal mortality ratios by state for 5 mutually exclusive racial and ethnic groups, which you'll see up here on the screen. And they pulled information from vital records and census data from 1999 to 2019. This graph is looking at the median mortality ratios for those 5 racial and ethnic groups. And really what I think is important is that it's not enough to look at this and take away that those who identify as Black have had the highest median mortality rate. What we can also see from this graph is that those who identify as Native American and Alaska Native have had a sharply distinct increase in their median mortality, maternal mortality ratio. Variability in risk of death by race and ethnicity has been quoted to be due to several factors. These include access to care, the quality of care, prevalence of chronic diseases, structural racism, and implicit bias. These factors are not mutually exclusive. We know that structural racism causes disparities in income, housing, safety, education, as well as other circumstances. These disparities are then associated with poor health and increased rates of chronic diseases, which place minority birthing persons at greater risk of pregnancy-related death from these chronic health conditions, such as cardiomyopathy, high blood pressure, diabetes, and more. Access, quality of care, and implicit bias further compound this in healthcare when minority birthing persons are less likely to have access to treatment and receive good quality care. I think all of us have heard that birthing persons of color are more likely to report feeling not listened to or respected by their providers, which further contributes to not only preventable morbidity, but mortality and delayed diagnoses of care. It's important to point out that disparities in maternal mortality are also noted to be different based on cause of death. Looking at this data that I showed previously from the different MMRTs, we can also look at this more closely by race. And what we see is one size does not fit all. While the prevalence of mental health conditions as the cause of death was highest and most prominent for those who identify as non-Hispanic white. For those who identify as non-Hispanic Black, the most prevalent cause is cardiac and coronary conditions. Hemorrhage is most prevalent for those who identify as Asian. This further highlights that there's not one fix to this problem and that there are many areas necessitating improvement. While the bulk of my talk is not focused on the disparities in maternal mortality, because if I did that, you guys would not be able to make me sit down. It's important to touch base on it though, because I think it contributes to so much of the numbers that we are talking about. The issues surrounding race and maternal health have recently come to the forefront of conversations due to experiences of individuals like Serena Williams, Shalon Irving, but it's not a new issue. So when Serena Williams, as you all know, an Olympic athlete, had a history of pulmonary emboli. After giving birth via cesarean, she relayed concerns of chest pain, similar to her prior PE to her healthcare team. She was dismissed as being confused from pain medications, though she was ultimately diagnosed with a PE in the postpartum period. Dr. Shalon Irving was an epidemiologist at the Centers for Disease Control and Prevention, as well as a lieutenant commander in the U.S. Public Health Service Commission Corps. She died 3 weeks after birth from complications of high blood pressure after 6 hospital visits and what has been described by her family as multiple pleas for her medical providers to help her with distress that she was feeling. Now that we've assessed the US as a whole, let's zoom in and take a look at our state. Again, a lot of what we're going to be reviewing comes from data from the Wisconsin MMRT. The current pregnancy-related mortality ratio published for Wisconsin is 7.2 per 100,000 deaths, and this is from data from 2011 to 2015. Data from the most recent Wisconsin maternal mortality report shows that over the years, the number of pregnancy-associated deaths have varied, with the highest year at this point noted in 2021 with 56 pregnancy-associated deaths. While the number per year in Wisconsin continues to vary, what we do know is that a lot of these deaths happen in the postpartum period. To show that trend, you'll see the graph below, which is data from 2016 to 2017. During this time, there were 80 pregnancy-associated deaths. 75% of the pregnancy-associated deaths occurred in the postpartum period. And this is similar to what we're seeing nationally in the US as a whole. What we also know from this 2016-2017 data is that the pregnancy-associated deaths disproportionately affected birthing persons who were between the ages of 20 and 29, had less education, lived in urban areas, and were enrolled in Medicaid at the time of death. This next figure is busy and doing a lot, but bear with me. This is from that same JAMA article that was published in 2023. And I wanted to display this result to mainly demonstrate trends in Wisconsin in mortality rates and how they've changed. This graph is showing the percentage change in maternal mortality ratios by state. And it's looking at the time period of 1999 to 2009 and 2010 to 2019. And it's looking at the change between the average maternal mortality ratios between those 2 time periods. So the darker the green, the higher the change was. From this study, we can see that the groups that experienced the biggest percentage change in their ratios in Wisconsin were American Indian and Alaska Native and Hispanic individuals. Specific numbers on maternal mortality rate between racial groups is currently being gathered and collected for our state by our state's MMRT. However, what we do know from 2016-2017 data is that while those who identify as non-Hispanic, Black, non-Hispanic, Asian, and Hispanic birthing persons account for only 1/4 of the live births in Wisconsin, they make up almost half of the pregnancy-related deaths. In Wisconsin, common causes of death that were reported include mental health, hemorrhage, and cardiomyopathy. Mental health as a whole in this category again included substance use disorders and overdose. Data from that 16-17 report in Wisconsin show that almost half of the pregnancy-related deaths in Wisconsin were due to overdose. Overdose as a cause of maternal mortality is continuing to become more common, and this again mirrors what we're seeing in the US as a whole. Because this is becoming a more common cause of death in our state, this is what I will focus on for the last half of my talk. In 2021, the Wisconsin MMRT released a report which highlighted additional information about our state and our data on pregnancy-associated overdose deaths. And the next slides in that data is from this report. This graphic is looking at pregnancy-associated overdose deaths from 2016 to 2019. Interestingly, half of the pregnancy-associated deaths from overdose are seen in the 6 to 12-month postpartum period. From an OB perspective, many of our last time points with our patients is at 6 weeks, which represents a missed opportunity to intervene for these patients. I would also like to point out that Medicaid coverage postpartum ends at 90 days, which again is a missed opportunity to intervene for these patients. Our state data also tells us that the age group most commonly affected is the 25 to 29-year-old age group. The distribution of pregnancy-associated overdose deaths from an age standpoint is the same as what we're seeing for pregnancy-associated deaths overall. We also know that overdose deaths associated with pregnancy, for the most part, are accidental. When reviewed, it was noted that mental health conditions and substance use disorder also contributed to 93% of the reviewed maternal overdose deaths for our state. Finally, we see that similarly to national data as a whole, the racial and ethnic group with the most deaths from overdose are those who identify as white. For the data examined, all racial and ethnic groups generally made up the same proportion of pregnancy-associated overdose deaths as they did total births. Notably, those who identified as non-Hispanic Black had the highest number of maternal deaths from overdose. They were also overrepresented in pregnancy-associated deaths from all other causes. For non-Hispanic Blacks, while only making up 10% of Wisconsin births, they accounted for 34% of all pregnancy-associated deaths. So what do we do? Knowing what the cause of our problem is here in Wisconsin is half of the battle. If we want to save the lives of birthing persons, it's imperative that we discuss some solutions. So I'd like to take some time to discuss some recommendations that are targeted at overdose in Wisconsin. The U.S. Department of Health and Human Services has a 4-pronged strategy for reducing overdose death overall. This includes primary prevention, harm reduction, evidence-based treatment, and recovery support. So the before, the during, and the after. Our state also has the added knowledge that has come from the Wisconsin Maternal Mortality Review Team, which has also provided some recommendations on how to improve our mortality rate secondary to overdose. The goal of primary prevention is to promote prevention activities. Some key aspects of this in practice include supporting and following protocols such as enhanced recovery after surgery, using prescription stewardship when prescribing opioids, providing funds to community organizations that are doing hard work in our communities to disseminate information as well as care related to harm reduction, as well as addressing mental health needs. The Substance Abuse and Mental Health Services Administration is a department within the U.S. Department of Health and Human Services, and they spearhead public health efforts to advance behavioral health in our nation. Their goal is essentially to make substance use and mental health services and research more accessible. The whole reason I bring them up is because they provide grant and funding opportunities that are targeted at prevention, and they post and forecast these grants every year on their website. One which I found particularly interesting was the one that you'll see here. This is the state pilot program for treatment for pregnant and postpartum women. The purpose of this grant is to advance family-based services for pregnant and postpartum women with a primary diagnosis of substance use disorder, to help state substance use agencies provide outpatient treatment and recovery support services for pregnant and postpartum women with substance use disorder, and promote a coordinated system of care for those with substance use disorder within our state. I say this to say that there is funding and resources out there, and that we as providers, public health workers, community leaders, et cetera, have to be willing and ready to do the work. One, to apply for these grants, but also to create the programs that are necessary to support and save birthing persons from a primary prevention and treatment standpoint. Harm reduction is a public health approach. It focuses on mitigating harmful consequences of substance use, such as transmission of infectious diseases and prevention of overdose. This is completed through care that is intended to be free of stigma, and it's centered on the needs of the individuals with substance use disorder. And this is important because we know that everyone who walks through our doors are not in a place where they're going to be ready to stop their current use. but we as providers have a responsibility to make sure that we're educating them on ways to stay safe. Research has been done on this approach, and studies have shown that harm reduction strategies, one, do not increase crime. They have the potential to decrease the incidence of HIV, hepatitis C, and overdose. One study that was performed by Hagen et al. Looked at the association between needle exchange programs, which are a proponent of harm reduction. It looked at those in Seattle and the change in drug frequency and enrollment and retention in methadone drug treatment programs. They looked at individuals who injected substances and compared those who had been in needle exchange programs to those who had not. And what they found was that those who had formerly been in needle exchange programs were more likely than those who had not to report a substantial reduction in their injection use of substances, to stop using altogether, and to remain in drug treatment. This approach includes many aspects such as clean needle exchanges, like I've discussed, naloxone distribution, fentanyl testing strips, as well as education on preventing, recognizing, and treating overdose. Within our community, Public Health of Madison and Dane County has a syringe services program with multiple locations throughout Dane County where no appointments are needed. And this is a resource that's designed to assist patients, like I said, in reducing their harm from substance use. They offer free supplies, such as the ones that you see here on the screen, which includes sharps disposal boxes, fentanyl test strips, nasal Narcan, and much more. These are examples of the educational materials that the syringe services program in Madison has. They are patient friendly, and they include instructions on how to test drugs for fentanyl, how to recognize overdose, where to get resources to avoid help, and much more. You'll see on the colorful handout, there's information on how to not use alone, where you can call and have someone on the phone with you to ensure that you have someone to call for help if needed. I can imagine that patients would feel much more safe and willing to talk to providers about their substance use if they saw posters such as these in our bathrooms, in our waiting rooms, of ways to keep them safe, next to those that talk about vaccines and stopping smoking, et cetera. While harm reduction has gained a lot of support, I'd be remiss if I did not briefly address what can be perceived as a clear barrier to harm reduction in our state, which is Wisconsin Act 292. This is a punitive law that allows the courts to take custody of an unborn child by ways of physically detaining a pregnant birthing person on the suspicion that they have consumed or may consume alcohol or controlled substances. While this law may seem like it may make it difficult to promote harm reduction in pregnancy, I'd like to point out a couple of thoughts. This act allows providers to report pregnant patients. It does not require it. More important from a trust building standpoint is that we're screening our patients verbally as opposed to drug testing them with urine and meconium testing, and that we're providing resources based off of our verbal screening. Furthermore, Act 292 should not decrease our efforts at harm reduction, because we should, as providers, be doing any and all things that are in the best interest of our patients, whether or not reports are needed to be made. I also would like to point out that we contribute to generational trauma, incarceration, loss of housing and employment when patients face legal repercussions that come from this act. And this leads to a decrease in access to prenatal care as well. So working to minimize harm from the consequences of Act 292 is also harm reduction. I'm not encouraging any of us to break the law by any means, but I am challenging us as physicians to know what our responsibility is as clinicians that are taking care of birthing persons and making sure that they know all of their resources. And I think that that also includes knowing about harm reduction. We know that pregnancy represents a time for reproductive birthing persons where they are motivated to reduce substance use and/or begin treatment. During pregnancy, standard of care for those with opioid use disorder is behavioral therapy and pharmacotherapy, such as methadone and buprenorphine. While this is a successful treatment during pregnancy, we find a lot of birthing persons stop treatment. More specifically, we see discontinuation of treatment or relapse, which is particularly high in the postpartum period. And this is thought to be secondary to many things, which include increased stressors of having a new baby, sleep deprivation, increased risk of mood disorders, loss of health insurance, as well as the threat of losing a child in custody. A study was done out of Massachusetts, that's a hard word, by Schiff et al., and it assessed the experiences of pregnant birthing persons with opioid use disorder, and it looked at their perceptions of the enabling factors and barriers to treatment utilization, as well as incentivizing factors for maintaining adherence. And they did this through comparative interviews. And through their interviews, they identified 4 main themes that were noted as barriers to medication for opioid use disorder use and adherence. Those themes included lack of agency and autonomy surrounding medication decisions. It included the hesitancy to use medication for opioid use disorder because patients wanted to minimize the risk of newborn withdrawal, a concern about the increased scrutiny and the potential loss of custody due to mandated child protective services reporting for opioid exposure at delivery in Massachusetts, as well as a perception that treatment environments like methadone clinics did not provide gender responsive or equitable care and had standardized inflexible visit regulations that were difficult to comply with in the early postpartum period. From an autonomy standpoint, the patients felt like they weren't given any other options for management besides medications, and many of those patients were deterred from trying to taper off medications when they voiced a desire to do so. You'll see quotes from interviewees on the screen, one of which was noted as saying, "Even my doctor was pushing me towards being on it. I just feel like if I'm saying I don't want to be on it, nobody should be forcing me or pressuring me to switch my decision or tell me things just to scare me," which a lot of the doctors did when I was pregnant, which is a reason why I didn't go. I stopped going to the clinic for a while. I just didn't go for a few months while I was pregnant because I just got tired of hearing certain things. With respect to themes on the concern about loss of custody, one interviewee was noted as saying, "It's a flawed system that just automatically assumes that because somebody is on Suboxone or methadone, that they're doing the wrong thing. It really creates an awful stigma having the time after you have your child be interrupted by DCF. I got home from the hospital to a DCF worker. That's horrifying. It's not appropriate. They don't do that to moms that are on any type of medication." For poor treatment environments, one interviewee noted, "It just exposes them to a different environment. When I was on methadone and I had my kids, I would have to bring them to the groups. It's a good thing they were allowed to be there. At the same time, if you have an older child, you might not want them to know, or you might not have explained things to them, or might not even plan to." I recognize that this study was done in a different state with different laws, but the takeaway does not need to be specific to that state, which is that there's a disconnect between healthcare providers and patients. As providers, we aim to always provide evidence-based care. However, how we deliver this care is important, and patients' perceptions of our recommendations affects their adherence. We should always make sure patients are as informed as possible when they're making decisions about treatment, and allowing them to play an active role in decision-making has a positive effect on medication adherence. This study highlighted that as providers, there was work to be done in ensuring that we're reviewing known maternal, fetal, and newborn risks, including detangling the idea of neonatal withdrawal with medication for opioid use disorder, that we're discussing the risks and benefits associated with discontinuing or not initiating medications in pregnancy, that we're addressing medication for opioid use disorder dosing changes that can occur throughout pregnancy and after delivery, and that we're talking about implications for child protective services reporting where necessary prior to delivery. Moving on to recovery support, these are services that are put in place to help increase long-term recovery and the quality of recovery for those who struggle with substance use disorder. We know that recovery is a process, and through it, individuals not only aim to improve their health and wellness, but to live self-directed lives. And these services aim at trying to make those things possible. In my research, I came across the idea of community support programs, and these are programs that offer coordinated professional care and treatment for adults who live with severe mental illness. Some of the key aspects of this include group therapy, help with daily living skills, social and fun events, as well as work adjustment training. This is a great resource for those with mental health those who struggle with mental health disorders. And we know that many who have a mental health disorder concurrently may also struggle with a substance use disorder as well. And for that reason, a lot of support programs like this one hold a lot of promise with helping individuals through their recovery. Similar to community support programs are community or comprehensive community services. Their framework is similar in that they aim to centralize resources to aid in recovery, but their work aims to stabilize those with not only mental health disorders, but substance use concerns as well. And some of the services they provide are here on the screen, which include job-related skills training, peer support, psychotherapy, wellness management and recovery, and more. Comprehensive community service programs exist actually in many counties throughout Wisconsin. I can say in preparation for this grand rounds and in my research that I did not know that these services existed. And I suspect that I'm not alone in this, which begs to reason that, this could be a potentially missed opportunity for us to be referring patients to these services for which they have to apply for. It could also stand as an opportunity for advocacy to increase financial support in this area to make sure that these services are able to continue for those patients. Finally, recommendations from the Wisconsin MMRT are made by reviewing summary events that contributed to the death of a birthing person. This includes clinical and social events. From those summary events, they will identify critical factors that contributed to the death, which is not always the cause of death. And recommendations are then made based off of those critical factors. They very frequently include support, access to care, policy, and these recommendations are geared at different entities, which can include individuals and families, providers, facilities, communities, and health systems. One of the recommendations from the committee surrounding maternal overdose was that health systems should coordinate with community programs to support pregnant and postpartum women with stable housing prior to discharge. And this recommendation was due to what was identified as a lack of available housing and homelessness for birthing persons. As physicians, what happens a lot of times is we may see someone from a labor and delivery standpoint who struggles with homelessness, and our initial answer is, let's place a social work consult. I think this recommendation is making light of the fact that there's a greater need. Wisconsin has programs such as DAIS, New Beginnings in Milwaukee, the Elizabeth House, that do offer these resources to assist patients with transition to stable housing. However, many times they're full with extensive wait lists. In June of 23, the Department of Health Services announced a new initiative to support homeless assistance providers to enable them to deliver housing services. And it provided funds to many different agencies throughout Wisconsin that included the YWCA here in Madison, the Homelessness Assistance Leadership Organization in Racine, and many more. And this allowed them the funds to do the important work to provide stable housing for our patients. Pulling this together, I think, if the agencies that provide this care are lacking in financial support to expand and meet the needs of our state, we as a system should consider looking into ways to help meet this need, whether that's through fundraising, donations, advocacy. This shows that there's a bigger need than what has yet to be met, and is a potential area of a promise with regard to improvement. Many of the recommendations from the pregnancy-associated overdose death report that came out are centered around support and access to care. You'll see them here on the screen. These are the first set with regard to support. The highlights that I took from this include that we as providers and healthcare system should make sure that we're addressing mental health after traumatic events and ensuring that patients have appropriate support services in place prior to discharge. We should be counseling patients on overdose in the postpartum period and with medication changes. That care services should be put in place and patients should feel encouraged to seek care even when they leave against medical advice. From an access standpoint, the summary of the recommendations include that we as providers should make sure that we're counseling every patient about contraception, that we should be connecting patients to resources for supplies such as nasal Narcan, and that we should be screening patients for mental health disorders and finding opportunities to increase access to mental health care. This leads to my last section, which is my kind of final thoughts, which are that, no number or no rate of maternal mortality should be considered acceptable to us. While structural racism historically has and continues to contribute to maternal mortality, it goes without saying that we as a system should place a stronger emphasis on implicit bias training. And I don't just mean what it is, but how to combat it in the workplace. I encourage all of us to feel comfortable with the uncomfortable conversations about bias in the workplace with our coworkers. I encourage us to feel empowered to highlight bias and improper care as we see it, as this is a necessary step to providing equitable and just care to birthing persons in our state. Maternal mortality highlights many areas of advocacy, whether it's through increased funding for community programs, laws to expand Medicaid coverage, contraception, and family planning services. Our voices do matter. One person alone, one health system alone can't fix this. We as providers of women's healthcare should strive to stay up to date on maternal mortality in our state, just as we would a new novel drug or surgical technique. That's how we can continue to focus our advocacy efforts. I charge us to be in collaboration with community organizations where there's already pre-established trust in the communities that not only need our help, but that we aim to help. And I charge us to walk into those meetings and those rooms with an open mind and listen with our hearts to the populations that are most affected. While a lot of these recommendations may seem like routine parts of the care that we provide, I implore you to keep in mind that if everyone was doing this from a routine standpoint, it would not be a recommendation. So finally, I ask that we continue to undergo self-assessment and look at the care that we are providing on a daily basis, how we screen patients, how we counsel them, how we recommend resources, and how we take care of the whole person. These are my references. I want to take a quick second to say thank you to Dr. Adams and Dr. Zapata, who mentored me through my grand rounds and answered countless emails, as well as Emily Moran Lozano, who provided the data about our state, as well as the Wisconsin Maternal Mortality Review Team, of which I am a part of, for the arduous and sometimes emotional work, but necessary work that they're doing for our state. I feel very blessed to be in the same room with so many amazing individuals who are trying to find solutions to the problem. I'm happy to take any questions.
Hi. One of the slides early on, I think compared the 2016 and 2017 data said like 68 or I always say roughly 70% of pregnancy associated deaths or pregnancy related deaths were mental health, like related to mental health conditions. And then it looks like in the more recent data, it was 30%. Can you account for that change, or has there been any discussion? And because 2020 to 2021, I don't think of as a not stressful year.
Yeah, so the beginning data is looking at like the US as a whole.
No, the Wisconsin ones, the Wisconsin specific 2016 and 2017, because I often tell patients that in the Wisconsin MMRT report, roughly 70% of pregnancy related deaths in Wisconsin were associated with a mental health condition or had that as component. And it looked like it was much less in the more recent report.
Oh, I see what you're saying.
But I don't feel like we've gotten better.
Right.
So I was just wondering if you could comment on that. Pretty significant, if that's thought in the committee that that's just random chance, or like why there was such a discrepancy between those two times that the data was released.
Yeah, I agree. I don't think that we've gotten better with our mental health efforts or our efforts from a substance use disorder standpoint. But I also can't pinpoint anything specific from like a time standpoint that would have caused the change in saying that mental health for 2020, 2021 was just happened to be lower than what it was for 16, 17. I would almost argue I would have expected it to be higher in 2020, 2021 with COVID and everything else that was happening. from a mental health standpoint. But there was nothing in the report from 2020, 2021 that specifically designated why it was higher earlier on, and now we're seeing less of those just for that specific year. For 2020, 2021, there were a higher prevalence of pregnancy-associated deaths overall in our state with 58, but I can't say specifically if that then contributed to why the deaths from mental health conditions was then lower.
Thanks so much, India. I just reviewed all this data myself for some reports, and I don't know if I have a reasonable comment for Amy's question, but I do think that the reporting is not completely up to date. And I got that from actually Jackie Adams, that, you
Mhm.
know, that sort of their review, there's a lag in reviewing cases. And so it may be that that's sort of apples and oranges, and we don't have the total picture because you don't want to report just real small segments of time. And I think the Wisconsin MMRT is working on a more comprehensive report to understand the past, 5 to 10 years.
That is correct. They're currently working on reviewing cases for 2021.
Exactly. So, but well done, and just so grateful for this presentation. It's such important work, and thank you.
Thank you.
Hi, thank you for such a wonderful presentation. And it's really great to know there are a lot of community programs available in Wisconsin. And I totally agree that we need more programs to support the mothers who are in need. But I was also wondering, like, the utilization rate for the current programs. Are we like maximizing the utilization of the existing programs, or can we still do the good job on advocating and advertising those programs to mothers?
As far as the comprehensive community support programs you're asking about? Yeah, I can say I did not look specifically into like what the utilization rate of those programs is. What I do know is that one, you have to apply for those services. So whether or not that's a barrier for patients of whether we're, telling patients to apply, I would presume that that's a potential area of improvement. But I don't know whether or not we're using those programs to their maximum benefit.
I see. Thank you.
Thank you.